Yeah, thank you, sir. At the outset, I am thankful for giving me such a clinical topic because most of the physicians are at crossroads whether to continue SGLT2 inhibitors in the patients of complaining with GU infection. Friends, we all know that we are in a GLP-1 and SGLT2 era, so we are voraciously using these kind of drug. But what are the mechanisms of glycosuria affecting for SGLT2 inhibitors or whatever so as per se disease, why glycosuria alters the characteristics of uropathogens, why there is altered gene expression and increased virulence, enhanced adhesion ability, and which facilitates vaginal candida adhesion and colonization, thereby increasing the risk of genital and urinary infection. And at that point of time, whether we need to continue that drug or not, I'm sure that at the end of my presentation, I'll make you something more comfortable regarding taking decisions. We all know that what are the risk factors for SGLT2 inhibitor associated for GU infections. They can be UTI or they can be GTI or mycotic infections, and we know that female sex is more vulnerable to that kind of complications, and when a patient of female patient comes with very high HbA1c, then we need to consider these kind of observations in our history, that whether patient is suffering from earlier GTI or male patient with uncircumscribed male, concurrent use of sulfonylurea and insulin, age criteria, then diabetic microvascular complications, then urinary tract obstruction or any anatomical disorder in that patient. But being physician, we always follow a dictum of balancing act, because balancing risk of GTI with other benefits of SGLT2 is paramount. We need to consider that SGLT2 inhibitors are now the drugs of this era because of so many benefits in heart failure, with reduced ejection fraction, with preserved ejection fraction, and there is high degree of well effects which can seen, which outweighs the ill effects, that is UTI, GTI, and for so many other complications. So we need to give benefit to and score that points, and then we have to decide whether we are going to that. So these topics from morning I am seeing these slides have been repeated, but I am not going to bore you, but I'll see and say the gist that if you start new SGLT2 inhibitor, then you need to think of that there is no absolute contraindicated in asymptomatic bacteria or history of GU infections. If you have a patient of recurrent GU infection, you should know the cause, underlying cause. You should counsel for perineal hygiene, because the good perineal hygiene which we don't use to manage in our Indian subset, because we are eat sari and other, we used to use such kind of clothes which are not so comfortable for managing perineal hygiene. Our toilets and public toilets are not so good. In our office area, we don't have good toilet activities. So that's why we need to go for such kind of checkpoints whether our patient is coming from that society or not. How educated is that patient? But a patient develops GU infection after taking SGLT2 inhibitor, then we should recognize early. We should give points to our patient, because when patient is complaining such things, we need to hear these things, and we need to continue in mild to moderate clinically stable severe GU infection. And if it is discontinued, there should be some life-threatening complication. Reassess, treat the risk factors, and again restart. But if SGLT2 reinitiation after GU infection, how to reinitiate? Because this we need to reinitiate because it outweighs the so many other good things. So monitor for signs and symptoms of GU infection which has occurred earlier. A patient knows now this time patient is somewhat managed earlier that kind of complication, so patient is automated for that kind of results. So if there is a recurrence incidence in highest within first 2 weeks, we know that first 2 weeks are very, very important when you start SGLT2 inhibitor. You need to reiterate the greater benefits of SGLT2 and keep on nagging that kind of knowledge to that patient, because the knowledge is the best way that we can give them patient a proper counseling. What are the real world evaluation? I am also part of this study. This is the Indian data, and we are proudly going to publish this data. Dr. N.K. Singh and Dr. Akash Singh is doing work. This is Genesis study. We have 15,426 patients, and the average age is 55.3, average BMI is 26, and by zonal distribution, almost part of India, except for some northeast part, we have taken all patients. Comorbidities, there was no significant comorbidities, or what we found that overall incidence of UTI is only 6.29, GTI is 4.6, and genitourinary infection, means combining both of them, we have only 0.73% of incidence in a very good data of 15,426 patients. And what was the difference in that kind of data? If you are using only SGLT2 inhibitor, then what is the incidence of UTI? DPP4 without SGLT2 inhibitor and SGLT2 inhibitor without DPP4. That kind of data is very good. When we dissected all those data, we found that SGLT2 without DPP4, we have greater incidence of GTI or UTI. And these incidence increases from 5.07 jumps to 9.09%. So that's why we need to have a formulation that we need to give this combo to reduce the incidence of GTI and UTI. Incidence by patient group, we can very well say the age group is independent. If the patient is more than 60 years or more, specifically if patient is more than 70 years, it is independent of UTI, means a patient with elderly age, if you are initiating or not initiating, it's an independent risk for GTI or UTI. Incidence by BMI group, obesity greater than grade 4, that is more than 32.5 of BMI, it seems to be an independent effect on incidence. See that in all of the groups, no SGLT2, DPP4 without SGLT2, SGLT2 without DPP4, and SGLT2 and DPP4. In all of them, we have, if the patient is obese, we have high incidence of obese, because obese patient is unable to take care of genitourinary perineal hygiene properly because of so many things. They are not able to see their private parts properly. They can't handle that kind of situation. So obesity remains as a key and independent risk factor. Incidence of comorbidities group, we can see that patient with CVD have significant higher incidence of UTI when treated with SGLT2 with or without prior DPP4. So there are very good things which has come up from this study, that highest incidence of UTI in time period of 3 to 6 months. So whenever you are prescribing a SGLT2 inhibitor, first 3 months are very crucial for education and perineal hygiene. So significant higher incidence of GTI if patient on SGLT2 without DPP4. So this is the Jai Viru. You can say that Amitabh Bachchan and Dharmendra, who has conquered that Sheohare picture at that diabetes is Gabbar Singh. So that UTI is if Gabbar Singh, then you are going to combine DPP4 with SGLT2, then you are probably going to get a good friend in treating these kind of complications. And now SGLT2, what we have given to world, SGLT2 as first line anti-hyperglycemic in management of type 2 diabetes in context of Indian setting. This is a systematic review and consensus by Dr. Avadhesh Kumar Singh, and we are ahead of world. We have given this statement in 2023. Now UK, we are 2 years ahead of this UK shift. Now the 225 guidelines from UK has shown again this, because SGLT2 inhibitor can be utilized as a first agent in view of so many things with level of evidence. You can see in the blue chart, and in class of recommendation you can see here. So definitely friends, we are in an era of SGLT2 inhibitor where we need to use these SGLT2 inhibitor voraciously, cautiously, and there are clinical recommendations for GTI adverse effects. And here the chart. If a patient comes with acute symptomatic genito-mycotic infection, there is poor compliance, patient is having not having earlier treatment therapy, then you need to start fluconazole 1 to 3 oral doses depending upon the severity. If patient is managed, then you can use topical also. Then this is the chart you can follow, because this is the simple chart we used to treat, because most of them are fungal infection and need to treat fungal infection at the earliest. Patient has a recurrent UTI, may need hospitalization. If patient suffer from severe kind of complication, when you need to hospitalize, and imaging a urological evaluation from a proper urologist should be done. So effect of combination, because talking on SGLT2 inhibitor and not talking of combinations, it's not be prudent. So that's why effect of combination of pioglitazone with SGLT2 inhibitors has shown that some things are favoring combination, something is favor control, and definitely we know that compared to pioglitazone alone, SGLT2 inhibitor plus pioglitazone improved glycemic control, reduced body weight, lowered blood pressure, but there are increased chances of GTI. So again, there is a combination, because we are in the era where we used to have FDCs, effect of combination of GLP-1 RA with SGLT2 inhibitor on UTI. Combining SGLT2 inhibitors with GLP-1 RA, there does not significantly increase the risk of UTI, as DPP-4 inhibitors has given good insight as a friendly relation with the SGLT2. SGLP-1 also, GLP-1 RA has also given a neutral relation. So, summary and conclusion, while SGLT2 inhibitors are shown to significantly increase the risk of GTI in clinical trials and real-world observations, and our own Indian study had slightly shown that the risk of UTIs are overhyped, GTIs are overhyped, we need to take in such further future meta-analysis to generate more and more data. So do we continue the use of SGLT2 inhibitors for patients complaining of GU infection? Yes, we can. We should think empirically, scientifically, and subjectively. Thank you so much.